Hello, good evening, everyone, and welcome to the fourth of the fifth in the series of everything you've always wanted to ask about diabetes and people of African and Caribbean origin. I'm joined today by fantastic speakers who are going to discuss a range of topics relating to getting the treatment right for diabetes and people of African and Caribbean origin. I'm Bernadetta De La Catrax, the founder and CEO of Diabetes Africa, which is a nonprofit organization that was registered in 2019 with the objective of improving diabetes outcomes for people in Africa and for people of African and Caribbean origin living globally. This event is part of the UK Expert Network, which is comprised of healthcare professionals, but also researchers and academics who are based in the UK, who have a passion for progressing treatment and outcomes in people of African and Caribbean origin in the UK. This event series would not be able to go forward without the support of our partner, Novo Nordisk, who have provided sponsorship, but have not had any input into the agenda, speakers, or content. But without them, we wouldn't be able to run this series of events. So as I mentioned, this event is called Getting the Treatment Right when it comes to diabetes for people of African and Caribbean origin. And I wanted to say up front that treatment doesn't just mean medications. It's broader than that. It's about the treatment of the individual overall when it comes to their diabetes care. And in this presentation, in this event, we're going to reflect that. So we're going to discuss the pathophysiology around how people of African or Caribbean origin might have a different journey to getting to diabetes. We're going to talk about the guidelines. And although there are not any specific guidelines for people of African or Caribbean origin, what can we pull out of that? And how can we inform the rationale for the treatment that is prescribed for people who have diabetes? We're also going to talk about differences in prescribing of medications that we might see. We're going to do a quiz to test your knowledge and get you involved. And then we're going to focus on the psychosocial aspects of diabetes care and what can be done to improve outcomes in the UK. As always, this is an interactive event. The speakers will be available in the chat. Please feel free to put your comments and questions and feedback in there. We want a lively discussion. And keep your eye out for the polls. Right, on to the event. Our first speaker is Dr. Louise Goff. Louise, can you introduce yourself, please?
Thank you. So I'm Louise Goff. I'm a reader in nutritional sciences at King's College London, and I've got a keen interest in the diabetes pathophysiology and how it differs in different ethnic groups. So I'm going to talk a bit about the African paradox today, focusing in on distinctions in the underlying pathophysiology of diabetes, and then think about its implications for clinical management. So this here is the treatment algorithm for hypertension. And this is one of the very few conditions in which the first line of therapy is decided based on the ethnicity of the patient. And so we choose a distinct first line of therapy for hypertension based on ethnicity. And the question that I really want to pose to the audience and also to the academic community that I work with is, do we need this sort of approach in type 2 diabetes? We know that type 2 diabetes presents with a great deal of variation. This figure here very much represents the kind of classical model of our understanding of the pathogenesis of type 2 diabetes. We very much focus on visceral fat, so intra-abdominal fat accumulation being the driving force behind the development of diabetes risk. Visceral fat accumulation, we know, leads to the deposition of fat in the liver, and it also leads to the deposition of fat in our muscle cells and also in our pancreas. And as a result of this fat deposition, we believe that insulin resistance develops. So we get hepatic insulin resistance, and we also get peripheral insulin resistance. And as a result of those insulin resistant sites, we obviously get reduced glucose uptake, and also increased glucose production. So we get a hyperglycemia. And this hyperglycemia is managed by a compensatory hyperinsulinic response. So this compensatory response is driven by two processes. The first is the pancreas hypersecreting insulin, producing more insulin, but also in combination and less focused on is the fact that the liver compensates by reducing the amount of insulin clearance we have. And so we're able to maintain a hyperinsulinemia through secreting more insulin, as well as reducing the clearance of insulin in the system. And as a result of this, we manage to maintain a euglycemia, or maybe just a moderately elevated glucose level, but we manage to keep diabetes at bay. And then the hyperglycemia of type 2 diabetes develops as a result of the pancreas failing, a failure of the pancreas to be able to carry on compensating for the insulin resistance. And that's the point at which we'll see the hyperglycemia of type 2 diabetes. Now, in populations of Black African ethnicity, we see some really clear distinctions in their presentation of diabetes and the characteristic profile of type 2 diabetes. So very consistently, we see that Black populations do not accumulate visceral fat. We've got lots and lots of evidence that at any body mass index, at any point in the diabetes development, people of Black African ethnicity will have much lower visceral fat than any other ethnic group, whether that's white Europeans, whether that's South Asians, whether it's Hispanic populations, lower visceral fat. We also know very reliably that they will not have high levels of liver fat, so markedly lower liver fat as well. But what we do see is a very marked hyperinsulinic response to any glucose stimulus in Black populations. And the evidence for why there is this high insulin response looks like it's mainly to do with a much lower clearance of insulin through the liver. So this high circulating insulin is very much driven by the liver having a much lower clearance of insulin. We also know that there are other distinctions in the presentation of type 2 diabetes and the risk factors for type 2 diabetes. So we very typically use the metabolic syndrome criteria to recognize people's risk of type 2 diabetes, very much focused on central obesity as a marker of visceral fat accumulation, and also the lipid abnormalities that partner the development of type 2 diabetes. But when we use these metrics, when we use a raised waist circumference, or when we use a raised triglyceride level, or the triglyceride to HDL ratio, we see that this is very unlikely to detect diabetes risk in Black populations. And that's because they're very unlikely to exhibit central obesity, and they're very unlikely to exhibit raised triglycerides, even though, of course, they are at a markedly higher risk of developing type 2 diabetes, hence the name, the African paradox. So with this in mind, my research group at King's College London has been funded by Diabetes UK to really explore in much more detail these ethnic distinctions in the underlying pathophysiology of type 2 diabetes. And we've wanted to understand the key processes in the development of type 2 diabetes: insulin sensitivity, beta cell function, hepatic insulin clearance, and also all those fat depots, visceral fat, liver, muscle, and pancreatic fat. And we've wanted to understand how these differ between men of Black African ethnicity and men of white European ethnicity. And we've done this mapping the development of type 2 diabetes. So we've recruited a cohort of normally glucose tolerant men, so perfectly healthy. We've recruited a cohort of pre-diabetes and also people with type 2 diabetes. And we've pursued a hypothesis that type 2 diabetes will be driven by early failure of the beta cell insulin secretory response in Black West African men compared to white Europeans. And so to fast forward to some of the main findings from the programme of work that we've been conducting over the last few years. Our principal findings have shown that in Black African men compared to our white European men, we've got an equal insulin resistance between our two ethnic groups. So we're not seeing an exaggerated insulin resistance in either of the ethnic groups. However, our Black African men have got distinctly lower visceral fat. And so this image here is showing the magnetic resonance imaging of the abdomen, a cross section, and the yellow colouring is showing the visceral fat, the intra-abdominal fat. And we see very reliably that that is much, much higher in our white European men compared to our Black African men. Also, our Black African men show distinctly lower liver fat and pancreatic fat. And when we looked at whether these fat depots were drivers of insulin resistance and beta cell dysfunction, we saw that they are in our white European men. Our white European men behaved exactly as the textbooks suggest they would. However, they were not drivers of insulin resistance or beta cell dysfunction in our Black African men. And they didn't tell us anything about those processes driving the development of type 2 diabetes. What we did see in our Black African men with type 2 diabetes was significantly greater deficits in beta cell function compared to our white European men. So at the point of having type 2 diabetes, the beta cells were more dysfunctional and had poorer function. So to think about the clinical implications of the work that we've been doing, I think firstly we have to recognise the heterogeneity in type 2 diabetes. It's got one name, but it presents with many subtypes. And those subtypes are probably linked with ethnicity, and they're probably linked with differential responses to treatment. And so we really do need to give quite serious consideration to whether we need ethnic-specific treatment algorithms and whether we need a different first line of therapy according to ethnicity. I would suggest that our data is showing that perhaps interventions which reduce the demand on the beta cell ought to be beneficial for Black patients. For example, low-carb diets. I would suggest that interventions which increase beta cell demand, for example, the insulin secretagogues, may be more harmful for our Black patients. And I would think that we really need to start considering protection of the beta cell in our decision-making around first line of therapy for our Black African and Caribbean patients.
Thank you very much, Louise. I'd like to now hand over to Charles Odiase, who's going to do the next section of the event. Charles, would you like to introduce yourself, please?
Well, thank you very much, Benny. So my name is Charles Odiase. I'm a consultant pharmacist in primary care and diabetes for the Decorum GP Federation. I'm also a diabetes care clinical champion, and I have a very special interest in improving type 2 diabetes management in primary care. So I've been asked to talk about the clinical treatment pathways and guidelines, but I must really say thanks to Louise for her presentation, because that has definitely laid the ground for the guidelines. So a couple of things to take into consideration. When you're trying to get the treatment right, you need to always consider the person living with diabetes, ideas, concerns, expectations, their beliefs. You also need to consider the critical high-risk factors that might be associated with that individual. When you look at the NICE guidelines, you have to look at it from the perspective of choosing the right medication for the right target that suits the individual. So the guidelines give you some cutoff points to consider. However, it still has to be an individualized target. Although the drugs on the NICE guideline is listed, it's not intended to be in an order of preference. It's just the list of medication that is included in that level of intensification. So I guess in a nutshell, when you look at the NICE guideline, you're looking at it as a guideline that gives you a definition of when to consider intensifying treatment in someone with type 2 diabetes, what available drugs are out there to manage hypoglycemia within the context of the NICE guideline, but also you also need to remember it doesn't take into consideration other benefits of newer type 2 diabetes drugs, such as improving cardiovascular protection and renal protection. The NICE guideline for type 2 diabetes, which is the focus of today's talk, doesn't actually consider anything beyond hyperglycemia. So this is more for hyperglycemia guideline. And as Louise said in her previous talk about the blood pressure guideline having ethnicity considered, the box, the content within the yellow frame is the only place within this guideline where ethnicity is considered. And this is around a medication called the glucagon-like peptide 1 agonist, where based on recent evidence, we do know that we need to consider different BMI cutoff points for different ethnic groups. And perfectly poised is this data that was released quite recently. I have to stress that, again, we've concise this data to simply reflect the main ethnic groups that have been researched in that paper. However, when it comes to the Black ethnic group, there was a wide variation of BMI variance, depending on how the Black individual classed themselves. So we had a BMI variance of 26 to 29, which varied between the Black British varied between the Black Caribbean, Black others. And again, I presume that the researchers would know that this requires further investigation. However, it's important to highlight that for the same cardiovascular risk BMI for the white individual at 30 BMI, the risk for a Black person is a lot less. On this diagram, as you can see, the average for a Black person will be 28.1, which is an equivalent risk of a white person at a BMI of 30. And as you can see from the diagram, the BMI threshold for this risk compared to a white person varies as a lot lesser. This is very important because when we start thinking about giving good treatment to people from the Black ethnic background, we need to consider going in early, providing them and prescribing medications that would actually offer them cardiovascular benefit, renal benefit early on, even if they don't reach the threshold BMI of your local guidelines. Right? So this is what we refer to as the American and the European consensus recommendation. It's very important to understand the difference between a guideline and a consensus recommendation. Reason being that the guidelines are, like the NICE guideline, is designed to review the cost and the effectiveness of the medication. Well, when we talk about recommendations like the American and European type 2 diabetes recommendations, these are simply based on the efficacy of the drug, how effective the drug, and they change quite regularly as it depends on how the data are produced. So the newer the data, they update their guidelines or the recommendations, whereas the guidelines do take some time before they're actually updated. And that's why if you notice in the UK, the NICE guidelines always lacking behind all the up-to-date recommendations from America or other parts of the globe. But when we look at this recommendation document, it's very important that you actually look into the different segments of this recommendation document, because it's gone as far as trying to accommodate every possible scenario. So from a case of low cost, if you live in a country where the cost of medication is quite expensive, or even the availability of medication is a problem, then there are options out there that you can have. But in the context of this event of trying to get the treatment right, it's a difficult one, because obviously cost will always be an issue, health inequality will always be an issue, But we do have data to support the fact that there's certain medications that will probably be better in terms of prescribing for people from the Black ethnic minority background, simply because they have a higher risk of certain complications and certain mortality risk. So if you look to my left, and you can see the writings in purple that talks about how we decide to allocate treatment for people at higher risk of heart failure or cardiovascular disease or from renal disease. Data does suggest the newer drugs, which we refer to as the GLP-1 agonists and the SGLT2 inhibitors, do offer better protection against these risk factors of heart disease, heart failure, and kidney disease. So again, this doesn't dismiss other medication, but as the slide goes on, I will explain to you the reason why I feel that when we are looking at guidelines and looking at recommendation statements, such as this one, that you have to really consider which medication will be best suited for the person from the Black ethnic community. So this is the main slide I want to spend a lot of time on. And this is about asking yourself, what do I have to consider when I have a person from the African or Caribbean community in front of me with type 2 diabetes? What should guide my rationale in my prescribing? So if you listened to Louise' presentation earlier, we talked about insulin resistance being equal between Blacks and whites. However, insulin resistance from the data does suggest that at a lower level of triglyceride, that resistance could be slightly different. However, nonetheless, resistance does exist. So when we're thinking about medications for managing people with type 2 diabetes, we need to start thinking about medication that could improve resistance, such as metformin, which we know does improve peripheral resistance in the muscle. So hopefully that will be a good drug to start with, which is the first line drug in most guidelines today. But other things that are probably not considered more regularly are things like cardiovascular disease occurring at a younger age in the Black person with type 2 diabetes compared to their white counterparts. For that reason, maybe an early intervention with drugs that improve cardiovascular outcome in people from the Black community with type 2 diabetes will actually be a prudent thing to do. One of the things we know from research data is that people from the Black communities are higher risk of developing elevated blood pressure, as well as retaining sodium in the kidney due to the lesser functionality of the renal system in the kidney. For that reason, it's probably prudent to actually utilize medications such as the SGLT2s and the GLP-1s that actually improve the loss of sodium from the kidney and also improve blood pressure outcomes. As earlier said by Louise as well in our presentation, we do know that people from the Black community have a lower beta cell function, which implies a lower insulin secretion. And this might be a case for arguing the initiation of insulin early on in the treatment of someone with type 2 diabetes. Nonetheless, it's very important that we don't focus simply on hypoglycemia, but ensure that even if we're trying to protect the beta cell and reduce the burden of the beta cells, we also utilize medication that improve the other risks that are quite pertinent to type 2 diabetes, which are things like diabetes, kidney disease, and cardiovascular disease. We also know that, as I earlier said in one of the previous slides, that the BMI cutoff points are now varied, and evidence is constantly suggesting that complications occur in the Black individual with type 2 diabetes at a lower BMI compared to their white counterpart. So it's very, very important that local guidelines at CCG levels in England and all the local boards across the nation are actually mindful of the local guidelines that restrict certain medications to certain BMI cutoff points. It means that we need to consider drugs that increase weight loss and improve outcomes for people with type 2 diabetes, especially from the Black ethnic background, earlier on, before we wait for them to get to BMI thresholds similar to their white counterparts. As we know, which is not a hidden situation, social deprivation often suggests high-calorie diet due to affordability. And we know that when you look into the African and the Caribbean ethnic groups in terms of their cultural diets, it's usually high on carbohydrates, which poses the risk of weight gain. And we know that with weight gain and other factors that's related to type 2 diabetes, an increase in weight gain could increase your risk of cardiovascular events. So offering people from the Black ethnic group early on medication that could actually improve weight loss rather than medications such as the pioglitazones, the glycoside that could actually create a burden on the beta cell function, but also increase weight gain will probably be more prudent to do. As earlier said, there is a higher risk of kidney disease in Blacks compared to whites. So medications are actually being provided now that we know have the evidence to actually improve and preserve renal function, even at the end stage, will actually be the best choice for people from the Black community to improve their risk of actually suffering from diabetes kidney disease. Another factor to consider are drugs similar to the pioglitazone, which we know increases the risk of bladder cancer. Although we have a lesser prevalence of bladder cancer in the Black community compared to the white community, we have a worse prognosis from a Black person that develops bladder cancer. For this reason, I think it would be prudent to actually avoid medications that we know could actually predispose people from the Black community to bladder cancer, and pioglitazone will be one of those. So to put it in summary, I would suggest that the properties of therapies that should be offered to people from the African and Caribbean community with type 2 diabetes should have cardioprotection as part of its property, renal protection as well, and also provide an insulin-sparing effect to reduce the burden on the beta cell function. We should be providing medication that also help with weight loss and reduce blood pressure and sodium retention. We should also be providing medication that improve insulin resistance, which will eventually reduce the insulin requirement. We should prevent, or rather, resist prescribing medication to people from the Black community that we know have a worse prognosis from bladder cancer, and reduce the prescribing of medication that might increase this risk, which include pioglitazone.
That's great. Thank you very much, Charles, for running through that insightful presentation, going over some of the guidance, consensus statements, and some overarching tips for prescribers on the best approach to take when they're caring for people of African or Caribbean origin with type 2 diabetes. I'd now like to hand over to Dr. Sam Seidu, who's going to be taking us through the next session of this event, and is going to be speaking about diabetes prescribing in Black populations. Dr. Seidu, could you introduce yourself, please?
Thank you, Bernie. Yes, my name is Dr. Samuel Seidu. I'm a practicing GP in Leicester and a part-time clinical lecturer at the University of Leicester. I'm also the head of research for Primary Care Diabetes Europe. So in this session, what I'm going to be doing, Bernie, is to talk about diabetes prescribing in the Black population. Just to review the evidence, we know over the past few years that there have been a lot of cardiovascular outcome trials published in the field of diabetes. And what is very notable in these trials is that the representation of Black population in these outcome trials is very minimal indeed. Most of the cardiovascular outcome trials have less than 5% representation from the Black population. Indeed, when they have stated the percentage of representation from the Black population, the definition of Black has been very variable from one study to another. And as you know, there's a very heterogeneous population in the Black race itself. It gets a little bit more complicated, but African Americans are not the same as Black Africans who have emigrated to the West. And a lot of these trials do not differentiate between these populations. So diabetes therapy intensification sequence from diagnosis to the end of follow-up by ethnic groupings has demonstrated in a recent publication in the UK that South Asians and Blacks are initiated with diabetes treatments quickly when the A1Cs are high. However, they do the intensification a lot more slower than the white population. The reasons for that we don't know, but it's worth exploring that in more detail later. At the moment, that hasn't been actually researched, so anything we say will probably be speculative. But that is the finding that we initiate quickly, but we don't intensify for the Black and South Asian populations as well as we do for the Caucasian population.
And just to clarify, Sam, when you say intensify, that's moving, as Charles has described, through the treatment pathway from metformin through to adding other agents. Is that correct?
That's correct, yes. And I even though I say we haven't explored it in detail, anecdotally, what I'm suspecting is these ethnic minority populations do not proactively engage in preventative treatment. So by the time they get to see their GP regarding diabetes, that will probably be a diagnosis. And if the A1C is very high at that stage, there is a high probability of the doctors starting some form of treatment. But then again, because there are no symptoms, when they start a treatment, they get probably lost to follow-ups and intensification does not occur. So this is just my anecdotal sort of explanation of why this could be the reason.
Okay.
So yes, at the risk of treatment with sodium glucose transporter inhibitor by race and ethnicity has been shown recently in a recent publication, just a few weeks ago actually, that this paper was published. And it's an important publication because it's looking at the trends of prescribing of these evidence-based medication. We know there is now a huge amount of data in support of SGLT2s, especially with respect to heart failure and kidney disease in patients with and without diabetes. And this study actually looked at the trends for prescribing these agents from 2015 to 2019. And as you can see from the graph, the trend has been that there has been an increase in prescribing rates of SGLT2 inhibitors. Another significant finding in this graph is that Black patients are lagging behind, even though there is an incremental trend in all ethnicities. Black patients are lagging behind by about 17% when it comes to prescribing of SGLT2 inhibitors. Data is from America, but we have a similar sort of graph for the UK population as well. And I think the importance of this graph is that we know from all the outcomes that Black patients with type 2 diabetes tend to have worse outcomes, worse cardiovascular outcomes. And so if there are evidence-based medications for cardiovascular disease prevention, one would expect that at the very minimum, they should be receiving these evidence-based medications at the same rates as the white population, and yet they're lagging behind. A follow-on commentary on this particular paper in Medscape suggested that this could be suggestive of inherent implicit bias in medical practice. So this is the data that I just alluded to earlier on, and that is from the UK. From Simon DeLucian's team. Again, similar sort of analysis looking at the RCGP primary care database, the ORCID database. And they looked at the proportions of ethnic groups prescribed SGLT2 inhibitors for type 2 diabetes in the UK. And again, as you can see, the Black population are lagging behind. That's the curve at the very bottom there. From 2012 to 2016, the Black population is lagging behind when it comes to SGLT2 prescribing. And we've got similar sort of data for GLP-1 receptor agonists, the same sort of trend.
And one thing that's interesting, Sam, is in the graph that you're showing is in the US, we saw that in Black populations, prescribing of SGLT2 inhibitors was lower than other ethnicities, but following the same trend. But here we're actually seeing with the UK data, which is slightly older, the number or the proportion being prescribed SGLT2 inhibitors is actually decreasing, as in the rate of increase is decreasing, if that makes sense. So in other ethnicities, the prescribing proportion is increasing, but the gradient for Black patient populations is less.
Yes, yeah, that's an important observation, Bernie. Yes. Yeah, even though all the curves are increasing, the exponential rise in the other ethnicities is not the same as you see in the Black population. The gradient is a lot, lower. And it's a very curious observation, actually, because in the UK, unlike in America, we have the NHS. And the NHS, as far as I'm aware, is free at the point of care. Nobody has to pay anything to use the service. And so there has to be a reason why something that is universally free for everybody is not being taken up by certain groups of the population. And so those barriers for access in the health service are the ones that we need to research in more detail to see what exactly is causing this problem. And so, yes, in summary, Black people are less represented in major clinical trials, and we need more data to be able to prove that the biology of the Black, population is not any inherently different. They probably would just react to these medications just like white Caucasians. There isn't any reason, any biological plausibility why their usage in these populations should be any less than other ethnicities. Less prescribing of newer evidence-based medications for cardiovascular and renal disease prevention is noted in the Black population in comparison to white population.
And it's also interesting, Dr. Goff presented earlier some potential differences in what is precipitating diabetes in different ethnicities. So, but you make the valid point, Sam, that without the data, we can't actually know for sure. So that is a call to action for everybody attending the event, either to perhaps get involved in more research or get involved in clinical trials. And in your role as head of research, do you see any incentives or initiatives to get more ethnic diversity in clinical trials or research?
Yes, I mean, locally, I work at the Leicester Diabetes Center, and we have a huge center for ethnic health in Leicester. And so we're doing a lot of work in BME populations, a lot of campaigns to improve representation from the minority ethnic groups in various research interventions. I think the issue is not just about patient recruitment, because as you know, there are a lot of skeptical ideas about recruitment, and we've discussed this in the past in other modules. It's a case of also making the researchers well represented to be able to convince the population to get recruited for these trials. That would at least deal with the skepticism that you face sometimes when you try to get patients recruited for trials.
Absolutely. Yes, you make a great point. We spoke about that in event 1, giving some extra background around why there might be some lack of confidence in the health system and research studies. Yeah. Wonderful. That has been an excellent run through. Thank you very much, Sam.
Thank you. Thank you, Benny.
We're now going to move on to an interactive segment that's going to be led by Charles and myself, going through some case studies. So Charles, if you'd like to take it away with the first case study, please.
Thank you very much, Benny, and thanks, Sam, for that beautiful presentation about the data that's available for trials in medication use in people from the Black ethnic group. So I've kept the cases quite simple because, as you can imagine, nothing is simple in the management of type 2 diabetes. But for the sake of this event, I've kept it simple, and we can actually discuss further during the panel's conversations. It's also worth bearing that this case is presumed that lifestyle intervention is the bedrock of every intervention that's offered to someone with type 2 diabetes. So our first case, so we have a 45-year-old Nigerian man with type 2 diabetes for the duration of 4 years. He's tried hard to work on his diet, and he admits that he has a high sedentary lifestyle due to the fact that he's a taxi driver. His BMI is 29.5, and his latest HbA1c, which is the way we monitor his sugar readings every 3 months, is 68 millimoles per mole. We're aiming for a target of 58 millimoles per mole or less for this individual. He's asymptomatic, so he has no osmotic symptoms with his diabetes, and is presently on metformin 1 gram twice a day and glycoside 80 milligrams BD. So for the sake of this case, there is no other complications or concerns or any parameters that we need to look at. And I guess the question to yourself is, what would you recommend from the following options? So increase glycoside to 160 milligrams twice a day, add pioglitazone, 30 milligrams once daily, add DPP4, one of the DPP4 that's available in the market based on the standard dosing regime, or add an SGLT2 inhibitor, or add a GLP-1 agonist, and finally add insulin.
So a lot of options there for people to choose from. If you should see something pop up on your screen now. It gives you the option to vote from A to F, and we'll go over the results shortly. So Charles, if you could give the correct answer and why, please.
So based on the case, it's good to always have a look at the case again. And if you notice, there's certain things you always need to consider when you were reviewing someone with type 2 diabetes. The age of the individual is vital, the ethnicity of the individual is vital, and the duration of the diabetes is also vital. This actually gives us an idea of how intensifying we need to go into managing this individual and what the risk and benefits would be depending on what medication we use. So for this case, I went with a GLP-1 agonist for simplicity. And the reason for that is that, as you can imagine, the individual is quite young. The duration of diabetes as well is quite shortened. And however, the patient is a taxi driver. So when we start thinking about the options like glycoside, based on the talks we've had so far, we know that glycoside could actually increase the burden on the beta cell function. We also know glycoside could also increase the risk of hypoglycemia. We also know glycoside could also increase the risk of weight gain. And this individual is already over the BMI cutoff point for a Black person. So it's very important that the goal of this therapy would be to reduce weight gain, and that would be by trying to see how we can get him off glycoside and offering medications that would actually improve his risk factors as a Black individual, but also improve weight loss as well as improve his HbA1c. An SGLT2 might have been a good option. However, because he's a taxi driver, there are concerns that he might not have enough time to use the facilities. So for that reason, a GLP-1 will probably be the most appropriate therapy for him that fits within his lifestyle, fits within his job, and will offer him the cardio protection that he requires, because we do have GLP-1s that offer primary prevention of cardiovascular events.
Excellent. Thank you, Charles. Moving on to case study 2.
So for case study 2, it's slightly more complicated, but nothing too different from the last case. So we have a 65-year-old African Caribbean lady with type 2 diabetes. Her duration of diabetes is a bit longer, so 12 years duration. Her BMI is 29. She struggles with her weight despite trying so many different diets and physical activity interventions. Her HbA1c is 75 millimoles per mole, which is a lot higher than the last case. And she's presently on metformin maximum dose, 1 gram twice a day. She's on a particular DPP4 inhibitor at maximum appropriate dose. And she's also on glycoside 160 milligrams BD. She's a stay-at-home mom. And similar to the former case, the last case, there's no other thing to consider. All the parameters are stable. So what would you recommend? So the options available to yourself include pioglitazone 30 milligrams once a day, the addition of an SGLT2 inhibitor, the addition of a GLP-1 agonist, or an addition of insulin.
Charles, so tell us, what did you do in this case?
So different from the last case, as you notice, again, it's the same process. We follow the same process. We look at the age, we look at the duration of diabetes, we look at the ethnicity of the individual, and then we look at the BMI. Similar to the last case, this lady is of Black origin. So the BMI cutoff point for this lady is a lot lower. So we need to see this individual, in the same light we would have seen a white person that's obese, class 1 obesity. The H-bone is also higher than the last individual, but the difference here is that she's a stay-at-home mom, so we're not really worried so much about having access to facilities if we give her a drug similar to as an SGLT2. However, similar to the last case, we probably would want to avoid the glycoside and reduce the glycoside. She's actually on maximum dose glycoside at the moment, and her H-bone-C is still 74 millimoles per mole. So for that reason, we're thinking, is the glycoside actually still effective? Because we do have data that suggests that after 3 years of use, the durability of glycoside and sulfonylureas as a whole actually declines. So it's always good to review these medications after a period of time, because yes, there is a place for them, but probably not suitable for everyone. So reviewing regularly is important. So in this individual, I considered giving her an SGLT2, halving the dose of the glycoside, and then reviewing it after 2 weeks with some food diary and home blood glucose monitoring. And then based on that, the plan was to keep reducing the glycoside with the view to stop it and initiating an GLP-1. This way, I felt I gave her the best option of losing more weight, giving her primary prevention for cardiovascular disease, giving her medication that will help her lose weight as well, and also stopping medications that would actually be a burden to the beta cell itself. And that's why those two medications in this case would have been my best choice. The pioglitazone obviously causes weight gain, so we've avoided that.
Brilliant, thank you, Charles. And on to the final case.
So the final case is slightly more complex. So we have a 76-year-old Jamaican man with type 2 diabetes, duration of 18 years. Which is quite a long time. So you're thinking about complications that already occurred, either due to clinical inertia or delay in optimization of his therapy. He's had a past history of stroke. He has chronic kidney disease. As you can see, his renal function is quite low at 32 mils per minute, and he has a high level of microalbumin. He is classified as a NYH2 heart failure status. His BMI is 31, which is a lot more higher than the last two cases, bearing in mind that his complications are actually more prominent. And he's on metformin 1 gram twice a day. He's on an appropriate DPP-4 at an appropriate dose. This individual is actually on pioglitazone maximum dose for the 5 milligrams daily. And he's on maximum glycoside as well, 160 BD. His H1C at the moment is 92 millimoles per mole. Similar to other cases, all parameters remain constant, nothing else to be concerned about. So I guess my question to you is, what would you recommend or what changes would you make? So the options we do have are to add an SGLT2 inhibitor, or to add a GLP-1, or to add in insulin.
Great, thanks everyone for voting. Charles, so what did you do in this case?
So unlike the last two cases, this question is quite more complicated. And there are a lot of things to consider here. So the similar process occurs. We look at the age, we look at the ethnicity, we'll look at the duration of diabetes, because that gives us an idea of how complex and how hard we can go in. We also look at things like the BMI as well. We've sort of reinforced that information to you today, that the cutoff point for people from a Black community is a lot more lower. And so for this individual, the BMI is quite very high. The patients already having complications from the diabetes. They already have chronic kidney disease. They've had a stroke. They've had heart failure. So in a way, we've actually approached this patient quite late in their type 2 diabetes journey. However, it's not without hope, because we have medications that could actually help this individual. So first things first. So as you notice, we've given a maximum dose pioglitazone, and we know that the dose of pioglitazone and the duration of use of pioglitazone increases the risk of developing bladder cancer. In this individual, the individual is already extremely overweight, already having renal issues, and we do know that pioglitazone is actually advised and contraindicated in people that already have a history of heart failure. So there's so many things going on here that we need to actually start thinking about why in the first place with this individual on pioglitazone. So the first step for me was to stop the pioglitazone to replace it with something else. I also left him on the metformin. So if we looked at the metformin, he's on maximum dose metformin, which is 1 gram twice a day, but his renal function is quite low. So if you look at the guidelines and you look at the information documents for the medication, the dose of the metformin would require reduction. The maximum dose will probably be 1 gram, depending on how stable above 30 his renal function is. So that would be something to actually keep a close eye on, because this individual required more regular renal function checks, 3 to 4 months. Other medications that we suggested were things like the SGLT2, because we do know that based on recent data that the SGLT2 does help improve renal outcomes for people with renal disease. We also know that the GLP-1s as well are also very useful at lower renal function, but also offer cardiovascular protection, secondary prevention from cardiovascular disease. So we felt that at this point, it's probably best to give them the drugs that would give them a better chance of having a longer stay away from further cardiovascular risk down the line. And so the aim was to stop the glycoside gradually by halving the dose and gradually introduce the newer medication, and then monitoring his glycemia response every 2 weeks to we're able to get him off the glycoside, stopping the pioglitazone, and then reducing the dose of the metformin, stopping the DPP-4 because there's no reason to prescribe a DPP-4 with a GLP-1, and then leaving him on a low dose metformin, monitoring the renal function, and then introducing the SGLT2 and the GLP-1 over a period of time. And this was over about 6 months. So I guess the take-home message for me is that you always have to remember that diet and physical activities underpin all type 2 diabetes management interventions. It's very important to remember that, because that goes through every plan that you create for someone living with type 2 diabetes. The most suitable therapies are the ones that actually improve the risk. And we've spent the time today trying to tell you how people with type 2 diabetes from the Black community are very, very different in risk and in the way their diabetes presents compared to their white counterparts. It's very important that when you're making rationales for creating management plans for people with type 2 diabetes, that you consider the right drug that actually meets the risk and improves their risk factors. Finally, I would say that we need to start thinking that poor diabetes outcomes that are seen within Blacks, are they actually down to their genes, or are they down to the fact that we don't offer them the appropriate diabetes care? So it's very important that we're reviewing the diabetes services that we're providing locally to ethnic groups, especially those from the Black community, to ensure that we're prescribing the right medications that suit them, offering them the right lifestyle advice that actually suits their culture and suits their lifestyle, their day-to-day living. Thank you.
Thank you very much for that, Charles. And actually the perfect segue into the next section of this event. I'm delighted to be joined by Dr. Natalie Darko, who's going to be talking to us a little bit about the psychosocial diabetes treatment adaptations and supporting resources. And then later on, we'll be joined again by Dr. Louise Goff to provide further information and an example of one of these interventions. And it's worth noting at this stage that treatment, getting the treatment right, just doesn't mean medications, as the previous speakers had alluded to. It's about the person holistically. And so the options that we're going to talk about now are actually also very important. So Natalie, I was wondering if you could introduce yourself, please.
Hi, I'm Dr. Natalie Darko. I'm an associate professor at the Stephen Lawrence Research Centre. I complete research mainly with African Caribbean groups and Black African groups, but also a range of ethnic minority groups focused around health inequalities, and improving culturally competent practices within research and clinical commissioning and everyday practice. So what I wanted to talk about today is getting the treatment right, but looking at other pathways. So particularly, I wanted to focus on social prescription. In basic sense, it takes the form of healthcare professionals such as GPs, nurses, and other primary care or clinical professionals referring patients with a range of conditions, or particularly diabetes, to different services, local, non-clinical services, to improve their health, well-being, and also to assist them in perhaps managing their medication. And again, these can be based mainly in the community, but they could also be in green spaces. So it could be referrals to walking groups, it could be referrals to a yoga session, or it could be refers to a community group. mainly which are delivered in community-based settings, but also in the case of this talk, they can also be delivered by minority ethnic communities or led in particular by African or African Caribbean groups. The aim of social prescribing is to consider or recognise that the health of the individual is also determined by a number of other factors. So whilst we can talk about the influence of an individual, we need to talk about the social, economic, the cultural and the environmental factors that can impact on that person's health and well-being, that ultimately impacts on their condition, their diabetes, but also how they manage that condition, but also how they view other aspects of their life, such as their physical activity and their diet. But it's important to think about, why do we need social prescribing? Importantly, we need it because it offers alternative treatment options. Both Louise and Charles have talked about getting the treatment right and made reference to different factors, notably cultural factors, health inequalities, etc., diet in particular, all of which can be influenced by your social context. So recognising that's important because it essentially could help the individual getting the treatment right, but also help the individual. So, for example, I've put a reference to the slide, a reference to an academic study coming up later. And within this study, if you take a look at it, it recognised it's an evaluation of an existing social prescription program or social prescribing program, and it's called Ways to Wellness. But within that particular evaluation, they found that 41% of the social prescribing participants all had type 2 diabetes. So if we recognise that, and we know that people are being socially or accessing these pathways, if a high percentage of those have type 2 diabetes, what does it tell us about treatment pathways that we should consider? So also within this particular study, one of the outcomes is that the diabetic consultations after accessing the social prescribing program reduced. So what culturally relevant resources exist for African and African Caribbean groups or patients living with diabetes? I know Louise is going to talk about the program that she's involved in coming up, but there's also some other options. And importantly, it's dependent on where you're located, and locating them or speaking to a GP, etc., or people within your networks is a good starting point. But if, for example, if you live within the region of Northwest London and you can access particular services through the clinical commissioning group, and there are culturally tailored activities for diabetic patients or people living with diabetes. And we've put some links in the slide. So, for example, there's a video that introduces you to diabetes, but has been culturally tailored for particular African groups. There's also access to a West African low-carb meal plan, and the focus on low carb, as highlighted by both Louise and Charles, particularly within African populations, seems to be relevant. So these resources are available in the slides and can be accessed through us. So if we move forward and we come back to social prescribing, there are lots of activities run within the communities that can be accessed. And it's about thinking about, what could you do as a patient to access these services? Most often, sometimes GPs might not be aware of the social prescribing options, so it may be worthwhile talking to them, your nurse, your local trust, even organisations such as Healthwatch or your local CCG. Visit different organisations. If you're London-based, there's some London Plus has access to different social prescribing activities. But also speak to your local communities and organisations and find out if they're actually running walking groups or activities that are actually getting patients referred onto, but you may not be aware about. So it's important to have a think about those and perhaps go and find some more information. And if your GP doesn't know, it's more than likely that they will find out for you. So what will happen next within a traditional social prescribing activity is that often you'll get a referral. You may be referred through your GP to a social prescriber or a link worker, but some also organisations allow you to self-refer. So particular ones, particularly in Brighton, you can self-refer onto the programme. And again, it may be because you may have other conditions that allow you to refer on. But what's essentially the element that fits with the holistic understanding of you as a patient or as the patient is the link worker would work with you and your family or your carer and work with you on giving you access to that activity, but also supporting you in accessing that particular program. So the link worker works with you and has a deeper understanding of you. So within the slides, we've put in some references, which allows you to look more at social prescribing, some links to particular organisations that can direct you to social prescribing, some academic resources, but also more importantly, and leading on to Louise's talk now, is access to a culturally tailored self-management programme such as HEALD. So over to you, Louise.
So thank you, Natalie. That's great. So I'm going to spend a little while telling you about our programme HEALD. HEALD stands for Healthy Eating and Active Lifestyles for Diabetes. And this is a culturally tailored diabetes self-management programme, specifically tailored to the needs of Black African and Caribbean communities. So we were well aware that there are a lack of resources out there to help our Black communities with their self-management of their diabetes. And we wanted to address that need through developing a culturally tailored programme. So this was a programme of research originally funded by the NIHR. We also wanted to ensure that the HEALD programme met the needs of the NHS. So structured education is a core component of diabetes management in primary care, and all patients should be being referred to structured education programmes. And we very much wanted to ensure that HEALD could be one of those programmes, so that it met the needs, it met commissioning needs, it met things like QOF outcomes. And so our work was to listen to both of those stakeholders, our people living with diabetes and our people caring for people with diabetes. So I don't have very much time to go through the richness of the information that our communities gave us, but this is just to draw on some key themes that came through and to illustrate to you how we used the community voice to inform the structure and the different components of the HEALD programme. So the communities talked extensively to us about the lack of cultural relevance in the care that they received. And so there's some quotes here. She didn't have a clue what we ate. It didn't really help me because it's not the type of food that we eat. And so this is referring to patients who have been to structured education or who have had healthcare interactions, maybe with a dietitian or a diabetes nurse, and that they didn't really find those interactions very helpful because the information just wasn't relevant to them. They couldn't go home and apply the information to the foods that they eat in their diet. They say we are obese, and this is because you're measuring a Black lady on a European chart. So we've got very, very strong rejection of BMI as a measure and a metric for assessing the need for weight loss. Our patient groups were very, very open to the need for weight loss, but they didn't want that conversation to be started through using BMI because it was deemed completely inappropriate to assess a Black body weight and shape on a chart that comes from European shape and weight. And so we had a very strong message to steer away from BMI in the HEALD programme. Going to the gym is not in my culture. You're being told you need to exercise, but what does that mean? And so we had lots and lots of themes around understanding the guidelines. What is exercise? Does it mean putting on Lycra and going to a gym? Because if it does, then that's a white person's thing and not a Black person's thing. Actually, you know, we walk and we dance, and those are what we do in our culture. And is that exercise? And is that okay? So we clearly needed to clarify the guidelines and what they really mean in a practical sense. Thanks. From our practitioners, from our healthcare professionals, we got very strong messages that they feel a lack of confidence and a lack of competence around providing care to their African and their Caribbean patients. This quote at the bottom, I don't think any healthcare professional can argue it differently because we're not providing for them at the moment. So this healthcare professional was aware that her diabetes clinic is mainly attended by Black patients, but she feels that she doesn't have the tools and the resources in her skill set to really be able to help those patients. So this is our curriculum. And then in terms of how we deliver that, here's some pictures from some of our sessions. There's a cooking session going on there. So some key components of the programme are that it's delivered in community venues, not medical settings, and that was at the request of the communities. They're group sessions, so they very much want the social support and meeting of others. They're delivered by a diabetes specialist dietitian alongside a lay educator, and that specific pairing was done to meet the need of credible advice. Patients were really very certain that they wanted their advice to come from credible individuals, but also the lay educator being able to provide cultural understanding and cultural relevance. We've developed up quite an extensive range of resources to help our participants. So we've got lots and lots of information booklets that have all been culturally adapted. They talk about culturally relevant foods and activities and risk factors. We've made lots of videos. We've got a nice video to explain diabetes in a culturally sensitive way. We've also got lots of case study videos where we've got patients who are sharing their stories to inspire their peers, and experts, healthcare professionals, for example, sharing advice. We've made exercise videos to do at home so that people wanting to exercise in the safety of their own home can do so and know that they're being given safe exercises to do. And we give our patients lots of things to encourage that participation. So they get exercise bands and pedometers, and they get tape measures to measure their waist circumference. That relates to what I said earlier about BMI. We don't talk about BMI in HEAL-D. We focus entirely on waist circumference. Waist circumference is something that patients were very interested in, and were very happy to consider the need for weight loss if their waist circumference was elevated and putting them at risk. And so we have a conversation around waist circumference, and we monitor waist circumference, and we monitor weight loss through waist circumference. So that's a specific component that has come directly from the community voice. We've done lots of food photography to help patients. We had lots of requests for how much can I eat? What should my plate look like? And so we went about making sure that we could give very visual guides to appropriate portion sizes, particularly around the starchy carbohydrates. Patients told us that they do not weigh things. And certainly I relate to Natalie's point about throwing the salt into the pan and not measuring anything. They told us that they measure with their eyes. And so we've used very visual portion size guidance using the hand and the fist. And so these resources are part of the program to help patients with appropriate carbohydrate portion sizes. I said that we do physical activity classes together. We needed to demonstrate to people what was safe physical activity and what was effective physical activity. And so we do 5 different physical activity classes over the course. We have a walking group, we do circuit training, we do strength exercises using the exercise bands, and we have a couple of exercise sessions based on dance and aerobics. So we do Zumba together and an aerobics class together. And so I'm going to finish just with some words from some of our participants who have been through the programme. And I think these really nicely illustrate what the program has been able to do for people. It's clearly been able to motivate behavior change. And we hear that particularly around portion sizes, around increasing physical activity, and around cooking methods. And it's also been able to provide support for people who felt they had a death sentence hanging above their heads. And actually, as a result of the education and the support that they've got through the program, realize that actually they're living with diabetes. And so I think these words really illustrate the benefits of being able to provide culturally sensitive and culturally appropriate self-management care for people living with diabetes. Thank you.
Thank you very much, Louise, and also Natalie, for running through the different options that target more psychosocial and cultural aspects of diabetes treatment and interventions. One question that was going through my mind while we were going through the session is actually, what has been the impact of the pandemic on these offerings, and what advice or what tips do you have for people who might want to get involved in things such as a HEAL-D program, given our current environment? I'm going to Louise first, please.
Yeah, sure. So we've actually adapted HEAL-D to a remote delivery program in response to the pandemic. So we've been running HEAL-D using video calling, such as this facility, to bring groups together. We run it as smaller groups than we would face-to-face, but largely we've tried to keep as true as we can to the original HEAL-D. We have exercise trainers do sessions with us, so we're all jumping around in our various living rooms, we are sort of providing social support through that means. It's been easier to bring people together from different geographical regions, but sadly some of the things that would happen through face-to-face HEAL-D, like people going and setting up their own walking group with their church, for example, and we had quite a bit of that. Unfortunately, that hasn't kind of happened through the remote program. But we have we have responded to the pandemic and tried our best to adapt and still provide support through the remote program.
That's great, Louise, and it is quite, it's obviously positive, but it is quite amusing to have people do virtual exercise classes. I've taken part in a couple of myself. It's a very odd experience, but it's great that you've been able to pivot so quickly. Natalie, I wondered if you had any comment on that.
So basically, in response to your question, Bernadette, one of the things that I think I've noticed within the current data I'm collecting at the moment is the impact of COVID, and particularly what Louise pointed on about discussions focused particularly on the spread around the stomach. There's a lot of talk within African and African Caribbean communities about the spread around the stomach because they've not been able to do the activities that they would normally have access to. And again, social prescribing activities had suffered, but most of the green-based ones, obviously the walking groups and outdoor yoga activities, etc., those things have been more accessible. So I think it's important to recognise that those activities have been quite good. But the other thing that, particularly within my own research, I found is, particularly amongst Caribbean elders, that access to the virtual space has been quite daunting for them, and still is now, even with talking to them and participating even in church sessions. It's very daunting teaching them how to use Zoom, for example. And I think working in a virtual environment is challenging, but finding ways. And one of the previous health interventions that I was involved in, which was teaching yoga, and I was teaching yoga to South Asian ladies. One of the things that I found within that particular study was that they like to communicate through WhatsApp. So when things stopped, they'd ask for a recording of me, for example, teaching yoga that they could send through WhatsApp. So again, same with African and African Caribbean populations. If they're not comfortable with the virtual world, they're sometimes more comfortable with WhatsApp, or not to plug WhatsApp, but some kind of platform over their phone. So having those recordings is another thing that they can do in their own time around childcare and other responsibilities, work, etc., as highlighted by Charles's case study for the taxi driver, etc. So I think there's ways around it, and Hildy has shown brilliantly how you can do it virtually. So I think hopefully we'll keep working virtually, but we'll have that face-to-face interaction, which is important as well.
Absolutely. And I'd like to say thank you very much, Natalie and Louise, for going over, I guess, this not as often thought of part of type 2 diabetes or diabetes treatment, which is the psychosocial, cultural aspect of care. And I'm really pleased that we've had a red thread throughout all the presentations that is thinking of the person holistically. That includes some physiological aspects. Then we're talking about the medications available in terms of metformin and other examples. And then we're looking at the social prescribing, which Hildy is a fantastic example of. So we're going to be moving on to the Q&A session. So please have your questions ready. We have some questions that were submitted previously, so we'll be going on to answer those. But thanks very much. Great, thank you everyone, and thanks for everyone who's still in the event. It's been a fantastic one. I'd love to thank our speakers, and if they could come back online with their video and audio, that would be great. So we've had quite a lot of discussion in the chat and some excellent points that people raised, but I thought we could open up the discussion by going through each of the speakers one by one and just saying, okay, so we've discussed the different aspects of getting the treatment right for people of African and Caribbean origin, but what's the next step in your particular area? I'd like to go to yourself, Louise, because you started off with a great example of the hypertension guidelines and how there is now some segmentation based upon race. With that in mind, what do you think is next for diabetes care?
Thanks, Bernadette. For me, it's a trial that gives us definitive evidence and data as to whether there is a more effective first line of therapy and second line of therapy according to ethnicity. So I think we've got really quite persuasive information that the presentation of diabetes is different, the underlying mechanisms are different, and so we would expect that the response to treatment would be different, but we haven't had that trial. So we've got poor representation of Black communities in the trials, but I think we need a trial specifically designed to test whether there is a more effective treatment algorithm, first line, second line therapy. So that's what I'd like to see.
Absolutely. Thank you, Louise. And following on from that exact point, I know in the chat, Natalie and Sam are raising the point of increasing participation of Black populations in clinical trials. Sam, you mentioned in your talk about the work that you're doing or the work that you're aware of to increase involvement. Gideon mentioned in the chat that they felt that some of the perceptions about research or clinical trials might be impacting. But I wondered if you had any comment on that or anything you've seen work particularly well.
Thank you, Bernie. I think it is important to continue to encourage participation from Black patients in research projects. At the moment, it's not the case. And I think from Gideon's point, there is that historical suspicion from the Black population from the Tuskegee experiment, which is an American thing. I'm not sure how much the UK Black population know about that. But if they do, it may actually be permeating into the UK as well. But whatever the reasons, we do know that there is poor representation. And I think one of the important points that I mentioned in my presentation is not just to focus on recruiting patients for trials, but actually encouraging Black researchers to spearhead this research. I think that would probably be more effective, because if they see the person recruiting them look like them, they are more likely to engage in the research than somebody that they're suspicious of because of historical reasons.
Absolutely, thank you, Sam. That's a great point. And going more to the practical, the prescribing, Charles, you went through the guidelines and the consensus statement. Have you found that in your practice and speaking with your colleagues and other healthcare professionals that there is a good understanding of a holistic view of treating diabetes in people of African and Caribbean origin when it comes to applying what the guidance and consensus statement is saying?
I would say, again, there's always been the conversation about individualized prescribing, individualized care. But for most of us that have worked in the NHS, that doesn't really happen because, as I said in one of my talks as well, there's always a cost-related thing relating to prescribing and managing chronic diseases. So the average clinician can't keep up with the changes that keeps occurring in the world of type 2 diabetes or even type 1 diabetes. So that in itself really poses a problem. Then you have the inequality issues where you feel that you're trying to prescribe for people that you can't really see all the time for whatever reason, either because of their economical status, they can't engage in clinic times and so on, and the systems are not flexible to meet their needs. So I think we've had a system that's not been flexible to meet the needs of the people that need it, which sadly seems to be a higher proportion of people in a social deprived situation. And then for that reason, we're not actually adapting to meet their needs. Rather, we're calling them hard to reach people, quote unquote. And that's why there's a big move to change that terminology to hardly reached people. We hardly reach them. It's not their fault, it's ours. So it's trying to see how we can adapt prescribing, adapt, processes at a local level, maybe not at a national level, but at a local level, because that's where the prescribing happens. And again, these medications are quite new. A lot of clinicians are not comfortable using them. So that's another problem as well, is trying to encourage healthcare professionals' education to get them to learn to use these drugs appropriately. A lot of people are not even aware of the risk and the situations we've talked about today, from Louise talk, from Sam's talk. No, people are not really aware of this. So it is a challenge. And I think that's one of the reasons why we are pushing for more specialist services at the local level in primary care, where you have lead GPs like Sam, specialist pharmacists, specialist nurses, social prescribers, becoming a team within the primary care sector to actually support the delivery of the service. So I guess the not sure answer to that is that we're still far away from actually prescribing appropriately for people with Blacks, because we're even struggling prescribing for people that are non-Blacks. So we're still far away from that.
Thank you for that, Charles. And I absolutely love that quote. I wish I'm going to put it on Twitter afterwards. It's not hard to reach, it's hardly reached. And I think that's an important distinction, and actually help people think about it in a different way. Moving on to social prescribing, Louise and Natalie. So I did a poll during the event, and 50% of people upon coming to the event didn't know that social prescribing was an option for people with type 2 diabetes. I wonder if you could speak on that in terms of the level of adoption or openness to adoption for healthcare professionals in your research and your conversations.
Yeah, I think it's really important. Obviously, it's. Can you hear me?
We can hear you with a slight echo, but please continue.
Oh, apologies. I think it's important that we know more about social prescribing. It's an available route through the NHS. So I think it's important to have those options. But also I think it's raising awareness, because particularly in the current climate, as we said, with green prescribing, those outdoor activities, gives people the options to do other things alongside their medication, and it offers alternative routes to community-based organisations. So I think it's definitely important, as Charles said, it's recognition of that holistic approach.
Thank you, Natalie. It was apologies for the sound. It was like you're in a very large stadium, but we did hear what you said. Louise, I wondered if you wanted to comment.
I would just add to that when we were developing HEAL-D, we did a lot of work with healthcare professionals to sort of understand, issues within their working environment that might make these things difficult. And it's little things like the referral pathways. And if anything like that is difficult and time consuming, then it's just not going to happen. And so I think when we develop these interventions, which are absolutely amazing interventions and so important for our communities, and certainly the patients that we spoke to who have participated in any social prescriptions, they've really valued them. But we've got to make it easy, because our healthcare professionals are burdened, and any little difficulty. So we talked a lot about free gym memberships and referrals for free gym memberships, and the healthcare professionals all said, I know that I can do it, but it's a really difficult referral form, so I can never get round to doing it. So sometimes it's things that seem quite small and irrelevant, but they're incredibly relevant to, when you're working within a healthcare system.
Thank you, Louise. Charles, you've got your hand up.
Yeah, so I just want to add to that, and hopefully Sam can confirm as well, is that one of the issues we have in primary care is that for whatever reason, clinicians over time have been taught to see social prescribing as an afterthought. So it's just the same way we had issues with lifestyle interventions and education in diabetes and so on. It became an afterthought. And the only way you could get this moving is to try and make sure that clinicians are aware of it as an integral tool, something you use first line, something you actually consider at every review, rather than something you consider when there's nothing else happening. So it's very, very important. And I think that's probably one of the steps we're missing, because even in our localities, when we have conversations about the next thing for diabetes and delivery and services, all the voluntary services are afterthoughts, and they should be at the center of it.
Wonderful. Thank you, Charles. Excellent point. I do agree, and the poll indicates that social prescribing is not at the forefront of people's mind. Louise, you've got your hand up, and then I would like to hear from Evan Jenga, who I'll introduce very shortly. So Louise, please go ahead.
I was just going to reflect upon the situation that we had with structured education, and the only thing that really changed referral to structured education was incentivizing it in primary care, and that really changed referral rates. So maybe we need to consider in a behavior change method such as money and incentives, and that might move us forward with these really important pathways of care.
Yeah, and then Louise, and that topic is consistent. We were working on a paper on sustainable diabetes educators, and one of the key threads that came up was that recognition and remuneration that's so important. We have Dr. Evan Jenga with us, which is a huge honor. For those who don't know Eva, she's a consultant physician in endocrinology and diabetes. She's chair of the NCD Alliance of Kenya and also chair of the Kenya Medical and Dentist Council. So, very honored to have Eva with us. And she's also one of the Diabetes Africa advisors. So that's our claim to fame. And one of the things that we pride ourselves for at Diabetes Africa is linking different networks together for a common cause. And so, Eva, I'm wondering if you would like to comment on, what we've discussed here about getting the treatment right and adaptations or things to consider for people of African and Caribbean origin, and I guess what that looks like or what that means to you in your setting in Kenya.
Thank you, Bernadette. And Greg, thank you so much for sending me that message. It's almost 10:30 in Kenya, almost ready for my bedtime. But I came a few minutes late, but so far the discussion is really interesting. Areas that nobody seems to be taking seriously, the issues of social prescribing, and also almost individualizing treatment to with the respect to the different traditional and cultural beliefs and cultural environments, especially Africa. And just in Kenya alone, we have so many different cultures. We have 40 different tribes. What might work for one tribe will not work for the other when you start talking about some form of exercises. I mean, there's nothing, yes, I liked somebody who said that going to the gym is more of an European or white man's creation. Because for the Africans, most of them, even if you're not in a white collar job, you have a job that or your work that you actually do physical work. So you go to your garden or your shamba in the morning with your tools and you dig, and you can dig for hours. And that to me is really serious calorie burning. So when you start to tell people about weighing their food and telling them this is what you need to eat, this portion, they'll just look at you and think you really are talking over your head, or you're just reading from a book and you don't seem to even understand the reality. Those are people who eat a very heavy meal in the morning because they know they are going to be in the garden the whole day digging, and they're okay and they're diabetic. So I think every education, and I really liked about structured education, talking about a diet that is relevant to the various communities. I think that's the only way. But then when you know most of these aspects of treatment, we don't really have published guidelines. I'm sure WHO or American Diabetic Association or IDF would not have guidelines along those lines. But I think this is where now Diabetes Africa, we must now be looking at this. And as we train our diabetes educators, these are the people we really must sensitize to look at these areas. When I look at the patients groups, because we have quite a number and strong Kenya Defeat, they call themselves Kenya Defeat Diabetes Association, that are present in very many of our counties. Kenya has what is called devolved health. So we have county governments that have their own health systems, health structures. The national government takes care of the referral hospital, the top level 6. The others will go 5, 4, 3, and 2. As we are now talking about the importance of primary health care, that is where we need to catch our people. And that's where we need to educate. That's why we have what people here we call community health workers or community health volunteers. These are people who have not gone to any medical school or any structured medical school, but you give them this kind of what I've just listened to, they are going to help so many patients. We are going to get our diabetic patients out there not ever getting maybe to require to come to level 6 with complications, because you'll catch them before they know what diet to eat, they know what kind of physical activities is adequate. So don't go and prescribe. I'm sitting in my clinic in Nairobi and I'm telling somebody to go swimming. The only water they see is a river passing by their farm. And so I think we really need to be, and this is, I really wish I had come earlier. So I'm going to beg Bernadette and Greg to send me the recordings, because
we will definitely send you the recording, Eva. And you make an excellent point that, especially for countries that are low resource in terms of the medication options, that the social prescribing that Louise and Natalie have described is so incredibly important, because when someone progresses, they don't have the options of those newer medications. But we are over time by over 30 minutes. Eva, thank you so much for contributing, and it's great to have you, especially that's so late. I'd like to thank the speakers, Louise, Charles, Natalie, and Sam. I'd also like to thank Novo Nordisk for enabling this series to happen. We have one more event left, which is on the 30th of June. We're talking about adapting to the pandemic. It's very relevant to the discussions that we've been having today about tailoring care and things that we should know about for people who have diabetes and are of African and Caribbean origin. Thank you to everyone in the audience who stayed well past the end of the meeting to hear us talk. And we'd love to see you at future events, or also join Diabetes Africa as members. So thank you, everyone, and have a lovely evening. Bye, everyone.